Our third controversy, and this is about post-neoadjuvant therapy in the triple-negative space, will be done by Dr. Heather MacArthur, who is the Clinical Director of Breast Cancer at the University of Texas Southwestern. She's a Komen Distinguished Chair in Clinical Breast Cancer Research. She's a medical oncologist with an MPH in clinical trials, and her research focus is particularly in novel immunotherapy approaches. She's held several national roles, including membership in the Breast Cancer NCI Immuno-Oncology Task Force and Working Group, and a similar role in the Alliance Cooperative Group. Susan Domchek is a medical oncologist and director of the Bassler Center at the Perelman School of Medicine at Penn. She's a nationally recognized expert in the translation of genetic testing for cancer susceptibility into clinical care. Her research interests include implementing novel strategies to improve uptake of genetic testing, further understanding specific risks associated with cancer susceptibility genes, and developing more effective therapies for BRCA1 and 2 mutation-associated cancers. And Dr. Domchek is a member of the National Academy of Medicine. Dr. MacArthur.
Thank you, Dr. Carey, for that kind introduction, and thank you to the organizers for including us in this novel, innovative session. So we're going to start out again with a case. This is a 38-year-old woman with a family history of breast cancer who presents with a palpable mass. She has a mammogram and an ultrasound that confirms a 3.2 centimeter mass by BI-RADS 5. Core biopsy is undertaken and reveals grade 3 invasive ductal carcinoma, ER/PR, and HER2 negative. Breast MRI confirms the findings above and no additional lesions. So she's a person who would have qualified for the Keynote 522 experience. Again, this is a study looking at essentially stage 2 and 3 triple-negative breast cancer, where 1,174 women are randomized to receive chemotherapy with a 4-cytotoxic chemotherapy backbone with either pembrolizumab, so checkpoint blockade in the form of pembrolizumab, or placebo in the neoadjuvant setting. And for those patients who were randomized to receive pembrolizumab, they continued to receive pembrolizumab in the adjuvant setting for up to 9 cycles. And this was the first look at the PCR that we saw after interim analysis 1. We saw that the intention to treat population had an improvement in pathologic complete response of 14%, and that benefit was observed regardless of PD-L1 status. So the rules that applied in the metastatic setting are no longer applying in the curative intent setting, and that delta in the PCR for the intention to treat population diminished over time with subsequent analyses to 7.5% at interim analysis 3. But at interim analysis 4, we saw the mature event-free survival data, which showed an improvement in event-free survival of 7.7% in favor of pembrolizumab. So a really remarkable improvement in cure rates in this high-risk population, which in my mind was really unprecedented. But the honest truth is that although 7.7% of the patients in this trial benefited, it means that the opposite must also be true, that 92.3% of patients participating in the trial did not benefit from the addition of pembrolizumab. And so how do we refine our treatment recommendations with that knowledge? And it's been a challenge. So if PD-L1 status isn't informing, or other biomarkers aren't informing our decisions about who should receive checkpoint blockade or not with curative intent, are there clinical characteristics that we could look at that could be informative? And unfortunately, that doesn't seem to be true. So when we look at subgroups, so here, for example, by nodal status, yes, you can see that the delta is bigger for those patients who had node-positive disease at 20.6% versus 6.3% for the node-negative. However, please note that the hazard ratio, so the relative risk reduction, is almost exactly the same for both of those populations. So nodal status may not be the information that informs who should get pembrolizumab or not. So what about disease stage, stage 2 or 3 disease? And the same really holds true as we just saw for nodal involvement. Yes, the delta is bigger for the stage 3 population, but the hazard ratio is almost identical for stage 2 or stage 3 disease. So that does not seem to be the clinical characteristic that can inform whether or not patients should receive immune therapy or not. And we can't ignore the survival advantage. Yes, those event-free survival improvements are translating into early improvements, approximately 3% improvement in overall survival as early as 3 years. And so we typically err on the side of overtreating our patients, but it would be wonderful to be able to refine these treatment decisions. So what can we learn from the existing data that has been presented over the last 5+ years? We know from the Gepper Nuevo study, so again, this is a study looking at neoadjuvant chemotherapy plus or minus immune therapy in the form of durvalumab. It did not meet its primary pathologic complete response endpoint. However, with further follow-up, median 43.7 months, we did see an improvement. This was not a primary endpoint, but we did see an improvement in event-free survival. So it begs the question, could a shorter course of immune therapy, because again, it was only administered concurrently with the chemotherapy, there was no adjuvant administration in that study, is a shorter course of immune therapy sufficient? And when you look, although we discourage sort of head-to-head comparisons, you can't help but remark how similar, with similar follow-up, these Kaplan-Meier curves are for event-free survival. So that's been a contentious question. The SWOG 14-18 study might hopefully inform these types of decisions. So the 14-18 study, just to remind you, is for patients with residual triple-negative breast cancer after neoadjuvant therapy, and they're randomized in the adjuvant setting to receive pembrolizumab or not. And it will attend to the question of whether pembrolizumab is successful in treating micro-residual disease in that setting. And so that data is highly anticipated. I want to hone in on a couple nuanced questions, I think, here. If you look at the event-free survival from Keynote 522 by pathologic complete response versus not, you can see that the majority of the benefit was derived for patients who did not achieve a pathologic complete response, a more than 10% benefit in that population. But you can see that for those who did achieve a pathologic complete response, that even patients who did not receive any immune therapy did extremely well, 92.5% event-free survival at 3 years versus 94.4%. Unfortunately, we don't have biomarkers that we can apply up front to identify patients who are going to achieve a pathologic complete response versus not. But it does beg the question for this population, is this a population who could forego adjuvant pembrolizumab if they indeed received the Keynote 522 neoadjuvant regimen and had a pathologic complete response? Could they derive benefit from a briefer neoadjuvant immune therapy exposure? Is this a patient population who could just be treated with chemotherapy alone, and how do we identify those patients? Could we actually achieve these same results with de-escalated chemotherapy in the neoadjuvant setting? And would rational biologic combinations achieve those same results with less toxicity? So there's a desperate need for upfront predictors to identify this patient population who has an excellent prognosis and might be able to have long-term cure without as much therapy. And so if we focus in on the patients who derive benefit from pembrolizumab, this is the delta greater than 10%, and the patients who do not achieve a pathologic complete response, how do we reconcile that with our prior standard of care? So previously, before 522 was reported, we treated patients with residual disease with capecitabine based on the CREATE-X study, which is shown here. You can see the overall benefit and the intention to treat population, which was really driven by the triple-negative breast cancer population, as seen here on the right. And that was further solidified in meta-analyses, including this one, showing that there was an actual survival benefit, that patients lived longer if they had access to adjuvant capecitabine in the residual setting. So as you're all aware, adjuvant capecitabine was not permitted on Keynote 522. And so how do we reconcile this survival advantage here in this meta-analysis with the overall survival data that I've shown you from 522? Well, we do have some data from the metastatic setting, including this study. This was an effort led by David Page, which looked to combine chemotherapy with immune therapy as first or second line therapy in the metastatic triple-negative breast cancer setting. And one group was permitted to have capecitabine concurrently with pembrolizumab, and co-administration was safe and effective in that group, although not a randomized study. So it may be reasonable to extrapolate from the metastatic setting that given the overall survival advantage shown with capecitabine in the meta-analyses and the survival advantage seen with pembrolizumab for patients who don't achieve a complete response, that this combination may be a reasonable consideration. And this is challenging, but further compounded by the challenges of patients who have germline BRCA mutation-associated breast cancer, and Dr. Domchek will touch on those controversies.
Thank you very much. So as our patient was undergoing her chemotherapy, she underwent genetic testing. She was of Ashkenazi Jewish descent, so our genetic counselor started with the Ashkenazi Jewish founding mutation panel. And I point this out because this is how these results are reported out now. This is called HGVS format. So those common 6174 del T, which is the common BRCA2, looks a little different to you now. So just be aware of that when you see these, is that the nomenclature has changed over time. However, a patient had a germline BRCA1 mutation. And so the question is, how does that now enter the scene? So as presented by Dr. Tutt at last year's ASCO and then published in New England Journal of Medicine, and most recent survival data updated in the Annals of Oncology, we looked in the Olympia trial at the use of olaparib in the post-neoadjuvant or adjuvant setting. So the schema is, as reported here, 1,800 women and men with BRCA1 and 2 mutations after undergoing either neoadjuvant chemotherapy with residual disease in the triple-negative setting, or a CPS greater than or equal to 3 for ER-positive patients, or for the adjuvant group, a triple-negative breast cancer, either with any node-positive disease or T2 disease, and for a hormone receptor-positive disease greater than 4 positive lymph nodes. So this was a high-risk population, but after they received all their usual therapy, they were randomized 1-to-1 to olaparib for a year versus placebo for a year. Please note, no immune therapy, no capecitabine was allowed. So unfortunately, we're trying to put together many different studies with how we approach our patients right now. The primary endpoint in this trial was invasive disease-free survival. So here are the patient characteristics, and I will go quickly through this just to tell you that the vast majority of the patients had BRCA1 mutations. That's in part because of how the study was initially designed based on FDA feedback, and it started off as a triple-negative breast cancer study. And as we all know, triple-negative breast cancer is more closely associated with BRCA1 mutations. About half the patients that had adjuvant therapy, half neoadjuvant therapy. About a quarter had had platinum as part of their treatment. In addition, the vast majority had triple-negative breast cancer, and about 75% had undergone mastectomy. And here are the data. For invasive disease-free survival, you see that there's a very significant difference at 3 years of 8 percentage points. Distant disease-free survival, again at 3 years, also 7 percentage points. And on the initial data, the overall survival was numerically different, but not statistically significant. However, these data were updated in the Annals of Oncology publication, and here for our invasive disease-free survival at 3 years, the difference is 8.8%. At 4 years, 7.3%, so it looked very similar. And very importantly, we see an overall survival benefit at 3 years of approximately 4%, and at 4 years of 3.4%. And as mentioned by Dr. MacArthur, to see overall survival benefits at 3 years into therapy is very significant and very meaningful for our patient population. So olaparib is a standard of care in BRCA1 and 2 mutation carriers who have high-risk early-stage breast cancer. Just wanted to point out that some of the things that people particularly worry about with a year of olaparib is either MDS or AML. And here, as you can see, in olaparib versus placebo, there was no difference in MDS or AML between the two groups. This is a little different than what you hear in the ovarian cancer story, but I do want to caution that in some of those ovarian cancer papers, patients had received multiple courses of carboplatin and Taxol, and only then had their PARP inhibitor. So I think we have to be really careful. Obviously, we need longer follow-up to be sure that this is true. Of note, numerically fewer new primary cancers were seen in the olaparib group, which just has this tantalizing hint of the potential to use this for prevention, which is a whole different topic. From a quality of life perspective, overall quality of life was maintained. Patty Gans presented data last year here at San Antonio with more detailed analyses. We know that PARP inhibitors cause nausea and fatigue, but overall, women and men do quite well on the drug. So can we give PARP inhibitors with immune therapy? Well, we published in Lancet Oncology in 2020 the Mediola trial. These were BRCA1 and 2 mutation carriers with metastatic breast cancer with olaparib plus durvalumab. And the answer is yes, it's safe. You get the side effects from olaparib, you get the side effects from durvalumab, but there does not seem to be any worsening of the two. In this study, however, the primary endpoint was disease control at 12 weeks, which was 80%, but the objective response rate was 63%, which is very similar to the Olympiad data, which was olaparib monotherapy. Now, this was a small study, and it was heterogeneous in terms of first line, second line, et cetera. But we don't see a dramatic difference when we add the two together. So the point is, do you need to add both together? And I think that's really one of the controversies. Here we see that the CREATE-X on the left for triple-negative breast cancer and the olaparib data on the right for BRCA-associated cancer. So it just gives you a sense of where we stand, that axes look a little bit different, but the overall benefit looks very similar in these two groups. So this is, Dr. MacArthur and I have sort of put this forth as a little bit of an algorithm that neoadjuvant chemotherapy plus pembrolizumab in high-risk early-stage triple-negative breast cancer at the time of surgery, if there's a pathologic complete response. The standard of care right now involves adjuvant pembrolizumab, although again, whether or not that is necessary is the point of future trials. If there's no pathologic complete response, if there's a germline mutation in BRCA1 or 2, olaparib is the standard of care. Pembrolizumab, I would add at this time, but I will tell you I have an extremely low threshold to stop it. And these are only in people who have already been getting pembrolizumab, not people who did not get it. And for those who do not have a gene mutation, capecitabine with the idea of plus or minus pembrolizumab. And Dr. MacArthur presented yesterday, and I refer you to her poster, the idea of using concurrent versus sequential pembrolizumab with radiation, showing that you can do both together. So that's a further point of consideration. So thank you for your attention.
Thank you. That was just terrific. So could we pull the poll back up? Oh, very good. Okay, so you've all seen this. Local management of T2N1 converting to node negative after neoadjuvant chemo plus anti-HER2 therapy includes the following. I'm just going to click and you guys can do your poll. Uh-oh. There we go. You have. And while you're doing that, can I just ask, for you guys, there was a question about low resource setting, no radioisotope. What are the options? How do you approach that?
I would say without dual tracer technique, you should do a node dissection.
Yeah. Thank you. Okay.
Hardly anyone.
Any comments about the results here, guys?
I think it's a good answer because radiotherapy to the axilla, I think radiotherapy to the first and second level, that is similar to axillary dissection, can spare axillary dissection, of course.
Okay.
But I think there are two different questions. One is ITC and the other two questions are linked to the possibility that you don't do anything.
Right.
As surgery. Okay.
Very good. Thank you. Question 2. Appropriate endocrine management of late relapse risk in an otherwise healthy woman includes all of the following except.
Whoops.
Nope.
Oops.
Uh-oh, that's not the right one. No, this is the wrong answers, wrong question. It was trick. Just seeing if you guys are paying attention.
Well, we'll see what the
Let it run?
answer.
Yeah.
We'll see what the answers are.
Let it go and then you'll go back? Okay. Well, in the meantime, there's CTS5. Can you use CTS5 in patients who are premenopausal at the time of diagnosis?
I mean, you can, but it hasn't been validated as well as in the postmenopausal patients. That was evaluated in the Taylor-X trial and did not predict as well in the premenopausal patients. So mostly in postmenopausals.
So, caution. Okay. Click back once. Okay. No. Can I click back again? No, we need. No. No. They don't like poll question 2.
Yeah,
We're losing poll question 2 here.
nobody likes it.
Okay.
It's, we'll give up. You can raise hands.
Nope.
It's,
All right. Well, this is not the question. There we go.
Oh, there you go.
Okay. Now you can vote. And we will, again, interdigitating. There were 2 questions about PAL-B2 and strategies for PAL-B2. Are they analogous or not?
yeah, it's such a great question. So PALB2 is the closest thing we have to BRCA3, and there's been publications. Nadine Tung through TBCRC has looked at olaparib in PALB2 mutation carriers, demonstrating in metastatic breast cancer responses. We've shown, Kim Rice-Binder at Penn has shown PALB2 responses in metastatic pancreatic cancer to rucaparib, another PARP inhibitor. So I think the data is pretty consistent. The problem is that the study is just not going to get done. And so we would love to look at that more specifically, but I think this is a case where I do err on the side of treating, even though we don't have the data in the adjuvant setting, but we're not going to get the data in the adjuvant setting.
Very good. All right. Katie and Terry, comments about the results of the poll?
I think we went up. So I think the right answer, the right answer is number 3.
Yep. Very good. All right. Now we're going to do number 3. Oh, no, now it went away.
We give up. It's okay.
We give up. Okay. Other questions? Come to the microphone. I'm going to look to see if there's any more online. We are at time. You guys did an awesome job with that.
There are people standing.
Other people saying, yes, microphone 3. Just identify yourself and.
Hi, I'm
Yep.
Suzanne, a breast surgeon from Singapore, currently doing a sabbatical in Korea. This is directed to Dr. Caudle regarding the first topic. I think I'm a proponent of not clipping. I think that sentinel lymph node biopsy is adequate. I just wanted to clarify on 2 things, because you were saying that if there is residual disease in the lymph node, it has both predictive and prognostic implication, because you may be leaving behind additional non-sentinel node disease, and that will also affect how we tailor our adjuvant treatment following neoadjuvant treatment. 2 points to it. One point is the paper that pointed out the percentage of non-sentinel lymph node mets in the MSKCC series is 67%. But that is for patients who has minimal residual nodal disease in the sentinel lymph node, meaning it is either a ITC or a N1-MYC. But we can safely think that for those that has YPN0 on sentinel lymph node, their percentage of non-sentinel residual nodal mets would be lower than 67%. In fact, in a study that we have just conducted, my percentage that we found for those that has minimal residual disease in sentinel node is actually just 27.5% instead of the 67.5%. We are very excited to publish that result. On the second note is that you were saying that if there is residual disease in the sentinel node, it will affect how we tailor the adjuvant treatment. But both in China and in Korea, we have already published our series which shows that complete pathological response in the axilla is actually higher than in the breast. So if we can show that there is no complete pathological response in the breast, even though there is non-complete complete pathological response in the axilla, it still won't affect our decision on the subsequent adjuvant treatment.
Thank you. Could you guys briefly address at least one of those questions?
Yeah, I can say, first of all, I think to your first question, the key for me is confirming that they have no residual disease. So, yes, we can say that if we know that, if there is residual disease, there could be more, but my point is that the false negative rate, we can make it as accurate as possible, so we're missing as few patients as possible that may have potentially not just a little disease, but could have, substantial disease. As far as the second question.
But I think that what she said at the end is if we have a PCR in the axilla, we may have in the breast a residual, and this can follow for give adjuvant treatment.
Yeah.
So you don't lose this information, I think.
Yes, that's why, because you have the breast to tell you.
I need to move on. Microphone
Thank you so
4,
much.
please.
Thank you.
Thank you.
Dan Morgenstern, hello?
Oh. Nope. Yep. Try.
Dan Morgenstern, Harvard, Connecticut, for Dr. Mamounis. Your comments on the HI and its interpretation within the B42 trial, having a little bit of difficulty with it. First thing you stated was that overall, the conclusion of the primary endpoint of the initial study was that it was a negative study. Is there something fundamentally different about using a biomarker such as the H/I within a trial that had a negative endpoint to select out beneficiaries versus a trial that had a positive endpoint to identify that subset that benefits? Additionally, you did 2 analyses of the H/I, one that was negative and one that was positive. Is there a need to correct for multiple hypothesis testing?
Yeah, good point. The B42 trial was essentially technically negative in the first presentation with 7 years of follow-up. At the time was a hazard ratio of about 0.85. With more follow-up, the 10-year results show significant benefit, but the hazard ratio is the same. It's about 0.85. So it's not a negative trial at 10 years. In terms of the results, the primary endpoint was negative. There was no significant interaction. It could be due to low power to detect the difference because the overall effect was modest. In the conditional analysis, we see that there is a benefit, although still the interaction is not significant. So it directs us towards more benefit conditionally for non-positive patients, but the overall result showed no significant interaction.
So is your bottom line based on a patient who would have been in B42 that such a patient, the H/I is or is not a useful?
So you need to take the totality of the data. As I presented, there were 3 studies that confirmed were concordant in terms of H/I being a predictor of benefit from extended endocrine therapy, and 1 study that did not quite meet the criteria based on the study. So I think you have to take the data in total and use essentially clinical judgment, but there is evidence that it does help and some evidence that is not concordant with the others.
Thank you.
Microphone 5.
I'm Richard Lynn from North Carolina. It's primarily for Dr. Mamounis, but I welcome input from the others. I remember the presentation of B42, and the indication was that cardiovascular toxicity started to appear after about 2.5 years. And that plus the Austrian study made me think maybe 7 to 8 years of an AI was optimal. And I considered that to be extended. Sounds like maybe we should say 10 years is extended. I'd like your thoughts on that.
Again, the totality of the evidence suggests that extended endocrine therapy benefits, but whether it is for 10 years or 7.5 or 8 years, it may be about the same. Because we tested 10 versus 5 and showed significant difference. Other studies have tested 10 versus 7.5 or 7 or 8, and they show no difference. So probably at least about 7 to 8 years appears to be optimal. If a patient has no symptoms, you want to go to 10, I think it's okay. But I think 7 to 8 would be also okay based on the data we have so far.
Dr. Vogel.
Can you hear me? Thank you. Vogel, New York. This is for Dr. Mamounis. Terry, the studies mix up patients who in the first 5 years had 2.5 years of tamoxifen and another group who started out with an AI. So I treat my patients systemically to prevent distant metastases and death from breast cancer. I don't care about local recurrences. I don't care about new primaries. That's me. Other people will do it differently, and some patients will care very much about the smaller recurrences that aren't imminently lethal. So if a patient has had 5 years of an AI, is there more than a 5% benefit in absolute benefit in reduction of distant metastases?
No, so far the benefit is a little bit less than that. And also the overview analysis has shown that if you have an AI followed by more AI, the benefit is less than if you have tamoxifen followed by an AI or some tamoxifen, an AI followed by an AI. So the benefit, the absolute benefit is less than 5%.
Yeah, so for a poor old man, when I have a high-risk patient, I give 2.5 years of tamoxifen, and then I tell them, I'm probably going to give you 5 years of an AI, and unless Mamounis presents another paper that says I should continue, I usually stop.
It's fine.
Thank you, everybody, for your attention, and thank you so much to the presenters for their hard work and their brilliant insights.
Thank you.